Good afternoon, everybody. My name is Victoria Lancy, and I am the Education and Communications Manager with Michigan Center for Rural Health, and I will be facilitating this program. We're going to go ahead and get started. I would like to welcome everybody to today's Geriatric Grand Rounds on implementing hypertension guidelines for older adults through shared decision making. This program is jointly provided by the MSU College of Human Medicine, MSU College of Nursing, Michigan Social Work Collaborative, and Michigan Center for Rural Health. Before we begin the program, just a couple reminders. If you're logged into the webinar portion and have computer speakers, you can listen to the audio through them. If you're listening to the program through the audio number, handouts are located on our website for you to follow along. Our website is www.mcrh.msu.edu. Click on the education link across the top, scroll down, find today's date, and then there you will see the presentation. Continuing education is available for physicians, nurses, and social workers at this time. Please note that there is a new process. There's no attendance form. Your registration was your attendance form, so the evaluation will be emailed out directly to you following the program. If you attended in a group, please send me a list of everyone that attended at your site with a first and last name in an email so that everyone at your site gets the evaluation link. The evaluation must be completed online and within 2 weeks or by October 16th. If you would like to ask a question during the program, please type it into the chat box so you don't forget it, and the presenter will address it during the Q&A program. Or if you have a question, please use the raise your hand feature, and I can also unmute you during the Q&A program at the end of the program. Our speakers today indicates no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support for this program. With that, I'm pleased to introduce our speaker, Dr. Catherine Donahue, who is an associate professor at the MSU College of Nursing. With that, take it away.
Okay, thank you, Victoria. I am Kathy Donahue from the College of Nursing here. I'm a faculty. I'm also a family nurse practitioner, and I practice in our family health center next door, seeing patients on a regular basis. Today, we're going to be talking about hypertension and decision making in terms of the older adult population. I'll be discussing the recommendations for treatment of high blood pressure in the older adult, describing the use of the shared decision-making process related to management of high blood pressure in primary care settings, and exploring the recommendations and evidence supporting the 2017 ACC-AHA, which is the American College of Cardiology and the American Heart Association high blood pressure guidelines. So why are we talking about hypertension? Primarily because it is such a common thing that we see in primary care, particularly with the new changes in the guideline recommendations of what's termed hypertension. It may be as high in terms of incidence as 75 to 80% in the older adult population. It is a leading cause of death worldwide. It's second only to smoking as a preventable cause of death. It can be successfully treated with lifestyle modifications and or medications. And as you all know, hypertension increases the risk for cardiovascular complications, especially with patients with diabetes or renal disease. And I think the other really important factor is that it's often a silent condition. Patients don't often know that they have blood pressure. They don't feel it necessarily, high blood pressure. And they, other than the few that have symptoms such as headache, most will just see this as something that is diagnosed in the primary care setting with a routine screening blood pressure. What about the hypertension guidelines? Well, we're all required to keep a focus on evidence-based practice. all of us in the primary care setting are also expected to meet certain metrics, which are related to the guidelines in terms of how many patients we're able to have who have high blood pressure, who meet like a guideline of 140/80. And then the challenge for the primary care provider, though, is really which guideline and which guideline are those metrics based on. Particularly with high blood pressure, the number has changed and vacillated back and forth, and we'll spend some time talking about that. And to determine which one to choose, of course, you have to evaluate the guidelines and the evidence that they're based on and make sure that they really do relate to the population that you're taking care of. And finally, in this slide, guidelines really are recommendations, and we still need to tailor each of those guidelines to the individual and make decisions using the shared decision-making process. I've been involved in shared decision-making for quite some time. I've done some research with researchers here at MSU related to coronary artery disease and shared decision-making. Shared decision-making involves listening to the patient and selecting the best treatment based on evidence. And without shared decision-making, patients may not follow through with the recommendations. Shared decision-making has been shown in some of the literature to require a little bit more time up front in terms of talking with the patient, but it does increase compliance in the end. So one of the other things about shared decision-making is that, again, it involves the patient, and we know that more than half of the medications prescribed are either not taken or not taken accurately. I think with the advent of the electronic health record, at least in our health record, this is a little easier to track because we can now go in and see if number one, when the medication was prescribed and when it was filled, and if it has been filled on a regular basis. So that's always a good thing to do when you're reconciling medications with the patients, to understand whether they're taking the meds or not. Shared decision-making, of course, is all about the patient preferences and values, but it's also about their knowledge in terms of how what they know about the disease process and what the outcomes are and why they're taking the medications. If we don't explain what medications are for and what side effects might occur, and then help them to decide which medication they'd like seems most appropriate, then many of them may stop. I know that oftentimes they don't tell you that. They will just come back and not have taken the medicine because either there were side effects, or the final comment here is about the cost. Prescribing medications is one thing, but actually filling them is another. It's important for us to always be aware that the patient in this day and age does usually have a cost. So looking at medication choice sometimes comes down to that as well. And particularly with the older adult population and the donut hole in terms of medications, we do have to be cautious and careful and talk to our patients about whether they can afford to take the medications that we're prescribing. The share approach is something that AHRQ has put forward, and I have the link at the bottom here. This is just, they've worked with the VA, and it's an easy way to remember how to kind of use the shared decision-making process. The first part of that is seeking your patient's participation, because, you know, there are some patients who say, no, I don't really want to be involved. I want you to tell me. But the vast majority in this day and age will want to be involved, and many of them come into the clinic or will go out of the clinic and get on the internet and find things that they think are more appropriate or have questions related to that. I do try with all my patients to make sure that if they are using the internet, that I provide them with some good sites, and particularly with hypertension. One of those, of course, is the American Heart Association. You then need to, the H is to help your patient explore and compare the treatment options. And we'll talk a lot about that today in terms of how different guidelines may differ. Assess your patient's values and preferences. There are those patients who just feel that medicines are not for them, or they don't like taking medications. I found it interesting the other day. I had a patient who came in and said, well, I'm just healthy. I'm really very healthy and I'm not taking any medicines. But yet his blood pressure was elevated and his cholesterol was elevated, and they had been for some time. And so he felt he was healthy because he wasn't taking medicines. The reality was he'd been recommended to do that, and his blood pressure would have been better and his cholesterol would have been better. But he felt, if he took medicines, that made him unhealthy. And so we had to have a long discussion about that. So you reach a shared decision with your patient. And in that case, he continued to decide that he did not want to take any medicines. And then, but next visit, we'll reevaluate that, and he may have changed some of that process. This is a really busy slide, so I don't expect you to take it all in. But I put this together based on one that was adapted from Cushman and Johnson as a reference later on. But this just shows the various recommendations that have been made around blood pressure over the years. Our first major one was the JNC7, which was, believe it or not, in 2003. JNC7 had just two categories of hypertension. They also had pre-hypertension, and the normal blood pressure was less than 120/80. As you can see, that normal blood pressure all the way across is considered, at least anything 120/80 or less is always considered to be normal in all of the areas. I did add in also the European Society of Hypertension, just because I was surprised at how different theirs was in some ways from the rest of the guidelines that we've seen. JNC7 had two categories of pre-hypertension, actually one, but they ranged from, the pre-hypertension ranged from 120 to 139. JNC8 called that the 130 to 139 hypertension if you were under 60, and if you were over 60, they had a higher stage. And then we now have the 2017 American Cardiology, American Heart Association guidelines, which also included a lot of others were involved in this, where normal blood pressure, again, is the 120/80, but 120 to 129 systolic is now considered high blood pressure, and 130 to 139 is stage 1, 140 to 159 is stage 2, and then they don't go beyond that. They always treat the same beyond that. So these are just kind of looking at the variations that have occurred over time, and I'm sure there'll be some additional variations, but you'll have to be able to discuss some of these with your patients. I also wanted to add one other guideline, which was from the American College of Physicians and the American Association of Family Practice, and these were guidelines specifically for older adults. And even though I hate to say 60 is older adults, that's what most people consider. So in patients, what they found, they used a meta-analysis. They reviewed, I think, 8 different meta-analysis and came up with these recommendations for individuals who are 60 and over. In patients, you should initiate patients treatment in those with a systolic blood pressure of 150, but their target was less than 150, not significantly lower. In patients over 60 with a history of cardiac events, though, you should initiate therapy at a systolic blood pressure of 140, and consider intensifying the therapy for those at high risk of stroke and cardiac events to achieve a systolic blood pressure of less than 140. They used, in terms of defining their evidence, as strong evidence being benefits outweigh the risk, weak evidence being benefits finely balanced with the risk. And the first one, the first recommendation is a strong recommendation, and the other two are considered weak recommendations. Again, areas by which you need to discuss with your patient and individually make that decision. So let's get on to the 2017 guidelines for prevention, detection, evaluation, and management. I say that only because really these guidelines not only put out recommendations about how they would diagnose and evaluate hypertension, but also the prevention. They really feel that it's really important for all of us to consider prevention on an ongoing basis. The emphasis in this one always, as well, in terms of diagnosis, was on blood pressure measurement. We find that there's a lot of variation in blood pressure measurement, and there's a lot of variation in how it's done. Most of us understand how it should be done, but in reality, it's often not done that way. In a primary care setting, I know that for me, what happens is our healthcare assistants will usually take the blood pressure, and they will take a blood pressure as the patient comes in the room. They have their electronic machine there, and they take the blood pressure as soon as the patient's in the room. We know that the recommendation is that a patient be allowed to sit quietly for 5 minutes at least, that they not have they've not smoked or had anything with caffeine to drink in the last half hour, that they are sitting with their legs uncrossed, that they are, and that basically they have their arm at heart level. And they also should take more than one blood pressure and then average the blood pressures according to this new guideline. One of the other things they talk a lot about is white coat hypertension and masked hypertension. We all are familiar with white coat hypertension. That's when the patient comes into the office and has this extremely elevated blood pressure, but may anywhere else have a normal blood pressure. Masked hypertension is less common, I think, or at least we don't diagnose it. That's when actually the blood pressure is normal in the office, but yet at home or somewhere else it may be markedly elevated. So one of the things that the guidelines talked a lot about was the consideration of doing, for really accuracy of blood pressure, to do ambulatory blood pressure monitoring. And this is where it's very similar to a Holter monitor, where they're required to wear the monitor for 24 hours, and their blood pressure is taken throughout that time, and then that's how we get the average blood pressure. Now, that's something that not all patients are willing to do or interested in doing. Also, there is a cost, although recently Medicare said they would cover that cost. That is the most accurate way to diagnose. Home monitoring is important both in the diagnostic process as well as in the ongoing management. It's really important that we talk to our patients about monitoring their blood pressure, just like the diabetics monitor their blood sugars at home. You know, it's fairly easy to get a blood pressure monitor, and they're all automatic now, so that patients don't have to figure out how to, pump up the cuff or anything like that. The biggest thing, both in taking it in the office and at home, though, is to have an appropriately sized cuff. And you also need to take the time to talk to them about how to take their blood pressure in terms of all the things we just talked about above. So the recommendations from the 2017 guidelines were a very high level evidence for the secondary prevention of high blood pressure. In other words, those who already have cardiac disease or other cardiac risk factors, and that's really what most all of the evidence is related to. There's a lot less evidence, a lot fewer studies that have been done on primary prevention. In other words, starting treatment when the only risk factor is really your blood pressure. So that just has not been studied as much. And the 2017 guidelines have a fairly heavy reliance on 2 random controlled trials, which I'll talk a little bit more about here. The first is the SPRINT, which was actually a random controlled trial that was done for older adults. It was one of the requirements to enter into the study was that you were at least 50 years of age. But also you had to already have what they now consider hypertension, the systolic blood pressure being 130 up to 180. Those were the criteria, and you could not have diabetes. So that's the population that was part of the SPRINT trial, and the SPRINT trial has been used as evidence of lowering the blood pressure in terms of better outcomes consistently. They did take a lot of the blood pressures, though, in a very kind of structured way. So people argue that maybe it's not, it can't be necessarily equivalent. I did take them in a quiet room. The patient was by themselves. They did all the things that we just talked about, and they took 3 blood pressures and then averaged them. So that's where they came up with their blood sugar. They had 2 groups, one where they tried to use very intensive medication monitoring and treatment to bring down the blood pressure to 120/80 or below, and the second group was 140/80, or a more typical kind of treatment. And they did find that there was a benefit in terms of lower risk, especially actually in those who are over 75, and they think that that probably was related to a higher incident rate. They actually, even because the data was fairly firm, they stopped this trial a year or 2 early. Another trial that's been used a lot is the ACCORD trial. And the ACCORD trial was, it was actually initiated because of diabetes. It was action to control cardiovascular risk in diabetes. So you basically, in order to be part of the trial, you had to have diabetes and hypertension. And they did a secondary goal of bringing that blood pressure again down to 120 versus 140. They found a benefit, but not a statistical benefit. One of the other trials that I'll just mention briefly in terms of the older population was that there was the HIVET trial, hypertension trial for the very elderly. And it reported more cardiovascular risk benefit with lower treatment goals, but didn't give any specifics in terms of the exact numbers, which is always the big challenge. Which number are we going to have as our goal? One of the other components of the 2017 guidelines is that particularly in the first category of hypertension, you have to decide whether or not the patient has a cardiovascular risk, and this determines how you will determine treatment in that category. The CVD risk is typically evaluated by a risk assessment tool called the ASCVD, which is the atherosclerotic cardiovascular disease risk calculator. This can be found on the American Heart Association website, and the American College of Cardiology has an app that's available so that you can have it in your office. The ASCVD events that are considered coronary death, non-fatal MI, and fatal or non-fatal stroke. And so it's prevention of those that you're looking at. Now there is, you look at the patient age, gender, cholesterol levels, history of diabetes, smoking, hypertension, and then that determines their risk. These are only for those who have not already had one of these coronary death, non-fatal MI, any other cardiac issues. And they are also only for those, the calculations are only for those who are 40 or above, but they did try to make some variation in it related to your ethnic background. This is a slide that's a little hard to follow because I couldn't find a good picture of it, but this is the ASCVD risk calculator, so it's very simple to do. You just click in male, female, total cholesterol, HDL, treatment, hypertension, smoker, systolic is really what they look at, diabetes, yes or no, race, and age. And then this all calculates and gives you a number. And that number is the 10-year ASCVD risk. In other words, a risk of developing any one of those cardiac events. The difference is that at 10% or above, you're to then change your treatment recommendations, 10% and below, or not below 10%, you don't necessarily start medicines at the first level. Now, I was working with a student the other day, and she said, well, what about, this person has pre-diabetes, they're almost at diabetes, what change would that make? And we did click into that, and it made a significant change in terms of whether or not the numbers, they went from maybe a 6% risk to a 12% risk. or an 18% risk. So just changes in a few things. So you wouldn't necessarily just do this once. You should do it with any changes in the patient's status. So basically, going back to the original recommendations, stage 1 is considered 130 over 139. And then you look at the ASCVD risk factor. For those who are below 10, it's lifestyle recommendations. And even those that are above 10, that's the first component that should always be initiated. I think we're all aware that weight loss or obesity is an issue and an increasing issue in our society. Encouraging weight loss, even a 10-pound weight loss, can make a significant difference in blood pressure. But I think this is one of the areas that in primary care doesn't necessarily get enough attention. It's a difficult topic sometimes to bring up, and it's also one that takes time to really talk about, set goals, monitor. And right now, unfortunately, we are still in a fee-for-service system primarily, so we're getting paid for the number of visits that we make. The other thing is, I think a lot of people are uncomfortable with discussing weight loss. Weight loss is a sensitive issue for a lot of people. There are a lot of recommendations that are coming out now about obesity management, and those are things that people should explore and get comfortable with. The first thing is, just asking, is it okay if we talk about, are you interested in talking about your weight today? Also, as healthcare providers, I think at least a lot of us have always felt, well, it should just be diet and exercise. That may be the case, and there's certainly a lot of variations on diets that can help. I really try to push them towards things like the Mediterranean diet, the DASH diet, which are just basic healthy diets. But we also do need to explore some of the other diets that people may want to do, like the keto diet. We don't know how that impacts blood pressure. We do have data on the DASH diet. And we do want to encourage exercise as well. But there are medications now that can be used to help people with weight loss. So you have to weigh the risk-benefit about, are those medications going to be helpful? Again, knowing the evidence around them. In addition, the other thing is to consider bariatric surgery. We do know that that makes a significant difference in both blood pressure and diabetes. Exercise, probably most of you are aware, at least 30 minutes, 3 to 5 times a day, ideally 5 to 6. But basically, it's not necessarily hardcore exercise. You do not have to be doing aerobics, walking, swimming. But when we tell people to exercise, we really should explore with them what they have available in their communities and what they've used before, give them some ideas, know community resources. I think smoking cessation is one that we're all very familiar with. The other one is the DASH diet. As I said, I think the key component here is the lower sodium content. And oftentimes when I say, to people, you should have a lower sodium diet, they say, oh, I don't add any sodium to my diet, so I'm just fine. But we all know that sodium is in everything. And many times if people were to go out to eat, they may get 1,000, 1,500 milligrams of sodium just in one portion size or even more. Even I've done a lot of label reading and looking at some of the healthy frozen diets that many people who are older or by themselves choose. They can have as many as 1,000 to 1,200 milligrams of sodium in them, even though they quote call themselves healthy. So helping people to understand that component. The Heart Association also recommends an increase in potassium can help to slightly lower blood pressure, stress reduction, lots of ways to do that, meditation, yoga, other kind of deep breathing. We all know that that's a good thing for all of us if we could manage to do that. The last one here in terms of lifestyle interventions is screening for recreational drugs and alcohol. Again, not always a common thing done and not always a comfortable thing to ask about, but it is very clear that certain recreational drugs increase the blood pressure, and certainly heavy alcohol use can as well. We need to talk with them about the idea that, you know, the 1 drink a day for women or 2 for men, and not binge drinking, because even though they may not do that, they may binge drink occasionally on a weekend and think that's okay. That's really almost more detrimental in the long run. So let's talk about pharmacological treatment in terms of hypertension, because this is usually what we're thinking about. Stage 1, again, is the 130 to 139, and an ASVD risk of greater than or equal to 10%. They do allow the patient 1 month to use lifestyle modifications to come to goal. And that, of course, is going to be a discussion again with you in terms of your patient. If somebody is at this level and wants to try longer than that, I often will let them do that, as long as they're making some very structured processes in terms of either weight loss or changes in activity, etc. Stage 2 is considered 140/90 or higher, and regardless of the ASCVD risk, you should start medicines. They do recommend reassessing in 1 month, and starting with 1 medicine, potentially 2 even, depending on how high the blood pressure is. But remember, this is a blood pressure that was taken accurately and at least twice in your office, and most people would say it should be 2 different office visits. The ACP and AAFP, of course, have a little more lenient way of starting pharmacological treatment. They do say for adults over 60 that you could consider the 150/90 for initiation of medications. And this is part of that shared decision making, because they are based on meta-analysis as well. And so interpretation of data, even with different organizations, can be different. And so we need to just make sure that the patient is aware of all of that kind of thing. They don't talk much about the risk, the ASCVD risk, but they do say they do have a lower threshold of 140/80 for those who already have diabetes or cardiac disease. So that they do feel that that's probably appropriate. So where does the shared decision-making come in? One of the first things that people are concerned about with patients, older patients, in relationship to blood pressure is this going to drop their blood pressure low enough that they'll be dizzy, at risk for falls or other, and do they have other comorbidities that put them at a risk for coronary vascular disease? So the way that we need to do this is to discuss the recommendations with the patient, educate them about their risks related to coronary vascular disease, diabetes and kidney disease, talk about how lowering the blood pressure in diabetes and kidney disease really helps in terms of long-term outcomes. And then you find an agreement between you and the patient. It may not be necessarily your choice, the way that you would do it, but you lay out the information, you give them options, and then you set goals. And it's really important to set those goals. It doesn't mean that if the patient says, I don't want to go on blood pressure now, blood pressure medicine now, that they won't ever want to go on blood pressure medicine. So they may go home, think about it again, get on the internet, do a lot of reading. They may decide that, maybe this is okay, and maybe this is important that I do that. Either way, they really, the guidelines recommend that you reassess in 1 month. They indicate that you should continue to do that for those that you give medications to until you reach your goal. And each time the patient comes in, again, the need to talk to them about how things are going, how the lifestyle changes are happening, and in addition to other questions that they might have. So recommendations for medication treatment. There are certainly several possibilities for first-line medications. In the past, this included the beta blocker, but beta blockers are no longer considered first-line treatment. Thiazides, ACE, and ARBs are the first-line treatment. It is important, though, that you don't put together an ACE and an ARB, so you do that in a stepwise process. African Americans have been shown to respond best to thiazide or calcium channel blockers unless there are other comorbidities that would encourage you to use the ACE. Considering comorbidities, I think most people are aware that with diabetes, an ACE or an ARB are important. And actually, the ACE has almost been shown to lower the blood pressure more, but may have a few more side effects. So you might have to go to the ARB. The majority of patients with stage 2 will need a combination of medications. So that, again, keeping them coming back and then seeing where they're at. What the recommendation now is often that instead of upping any one medicine to its absolute maximum, because that then increases the possibility of adverse effects, that you consider, the typical dose of that medication and then adding in a second, because as everyone is aware, each of these really impacts different areas of the body, whether it's in terms of the fluid retention or the kidneys or whatever, and makes the changes in different ways, so that basically the addition of another medicine may bring down the blood pressure more effectively. But monitor closely and consider labs, especially if you're using a thiazide for potassium levels. And also you need to monitor renal function. There was not a specific recommendation in terms of labs that need to be done prior, but I think we all probably would agree that we need to make sure that the kidney function, liver function, so a routine lab work is important, and renal function is very important because that will determine to some extent the medications you're going to use. Many of the older guidelines also had indicated that we should do an EKG prior to starting hypertensive medicines, and that's still standard of care in a lot of places. I don't know that we have much evidence to support that because, again, it's just not something that has been studied. So why do people not stay on medicines? What they found in the studies was as they tried to lower the blood pressure, they added more meds, they got more side effects, and people actually dropped out of the studies. But I think we need to make sure patients are aware of adverse effects. Potassium, loss of potassium, sodium, so we need to monitor these things. Edema can, certain medications, particularly the calcium channel blockers, can cause edema and have more difficulty with heart failure. I think one that doesn't get discussed as much is the erectile dysfunction, but according to some of the information that's out there, that's one of the reasons that a lot of men go off medication. And the thiazides are actually a big player in that, and also the first generation beta blockers. It seems that the ACE and the ARBs and calcium channel blockers are less likely, but erectile dysfunction is a multifaceted disease. Some is psychological in terms of stress and other things, as well as hypertension itself, and coronary artery disease can affect it. So can if a patient has diabetes. And I think, so the outcome there is that everyone should have that discussion and make sure that patients understand what that component might be. Having multiple medications and timings is not necessarily an adverse effect, but the combination of medications can be problematic. Also, when you think about with patients, so many of them as they get older may have, 6, 8, even 10 meds that they're trying to take and trying to figure out timing and when to take them and how to take them. It's important that we spend the time talking with them and doing med reconciliation, helping people to understand what their medicines are for. Just last week, I was looking at a list with a patient, and he wasn't sure which ones he was taking. And he then just said, I don't really know what any of them are for. So we sat down, went through them, and kind of talked about, the best way to take them, why they were taking them. And we ended up taking off one of them, because that's the other thing. Don't forget that just because medications have been prescribed, it doesn't mean that a patient's going to be on that medicine forever. making sure you're not duplicating medicines, as I said, not adding an ARB when you already have an ACE on board. Then the last thing I wanted to talk about here in terms of adverse effects is that as people get older, the pulse pressure can be wider. And so isolated diastolic hypotension is also a concern. You might have a blood pressure that where the systolic is certainly in the range that you should be treated, but the diastolic tends to be much lower. So you kind of have to talk with the patient in terms of the risks and the benefits. We always think about the risk with low diastolic of being dizzy, lightheaded, potential falls, but there's also been a number of studies recently that have showed adverse outcomes, cardiac outcomes, when the diastolic goes too low. So just being aware of that in terms of some of the adverse effects that can occur. So considerations in the older adult, again, depending on the comorbidities, what other things are happening for that patient. If a patient isn't, feeling well, if they have cancer, if they have other things, what's their priority? Do they want to lower their blood pressure? Do they want to add another medicine? What's the life expectancy? Looking at all those things. In contrast, if they have diabetes and potential kidney disease, they really want to bring that down, and that will really benefit in the long run. Again, the risk of hypotension, and so you may need to set the goals a little higher, the 140 or the 150 versus 130, which is the most recent recommendation. And be aware of the diastolic numbers, which could be even low with a high systolic. Also, consider deprescribing if they're lightheaded or their blood pressure levels change. One of the things that is sometimes forgotten as people get older, they do sometimes lose weight and lack of nutrition, or they're maybe actively losing weight. We need to be sure that we're monitoring their blood pressure and removing meds if that blood pressure is going lower, if they're making lifestyle changes that make a huge difference for them. Or sometimes it's stress, they may have retired and now they're more active and their blood pressure actually is below 120/80 and they're still on several hypertensive medicines. You need to consider taking them back off some of those as well. So in summary, you need to review the evidence and identify recommendations that you want to follow. You have to be very comfortable that you know what the evidence is and that you feel it's strong enough to support making these recommendations to your patients. And share with the patient the different recommendations for risk and benefit. Determine a clear plan of care. Make sure the patient understands that. Reevaluate on a regular basis. And I really want to caution people before adding or increasing medications, make sure the patient is following the plan of care and taking the medications that are already prescribed on a regular basis. Many times when I say, well, looks like your blood pressure's, quite high today, we may need to add another medication. And then I start talking about the meds that they're on. I may find either by looking in the chart or the patient themselves may indicate, well, I'm really not taking that medicine. I'm not taking it because of the side effects, or I'm not taking it because it was too costly. So then you need to consider alternate plans with the patient. One of the things about cost I just wanted to add was that I'm finding sometimes that I'll give a prescription and patients will find maybe it's not on their formulary, and so their copay is significantly higher. They may decide not to take the medicine, but they don't let me know that. So I'm actually talking to the patient about if for some reason you can't afford the medicine, please let me know, because we can then think about changing it or maybe getting some support for that through the pharmaceutical companies, so that they have that they're given permission to call back if they can't afford a medicine or if that medication copay is just too much. I did want to take some time now, Victoria, then for questions. And if we have time after that, we can do the case study. Victoria?
Yep, sorry about that.
That's problem.
I have two screens and my mouse wasn't moving.
Okay, no problem.
We have one question right here so far. It says, can you advise CDL exams and similar and claims of white coat HTN? Any tips? And then she says, I always talk about caffeine.
Okay, I guess I don't understand the question. Could the person come online and ask it?
That she just typed it out. Tracy Texter, do you feel comfortable coming on and verbally asking your question if I unmute you?
Yes.
Okay, go ahead.
I do CDL exams and patients will say, oh, I have white coat hypertension. It's not that high really. Mm-hmm. And they won't pass the requirement of being 140/90 or less to get the CDL medical card.
Okay.
Do you have any tips?
Well, I think you're going to have them, obviously have them back. That's a challenge because that's a rule. There's no way around it. For myself, in terms of determining primary care treatment, what I do is that if they can validate that their blood pressures at home were lower, that they go and record them and get those lower pressures, then I'm okay with that. But for an exam like that, you might have to resort to the ambulatory blood pressure monitoring if they, in order to meet the criteria.
Okay. Yeah. We're very strict on it, and so far we just say, you got to do it, and if they need medicine, then they have to come back, and there's a mechanism for that. So.
Yeah, and I think that you're right, that one of the biggest things is making sure that everybody's accurately doing it, that they're giving them the time to rest, that they're taking two and averaging it, all of those things that can make such a big difference, and that they haven't had the caffeine, that they haven't been smoking, any of those could potentially alter it. And I think also potentially looking at alcohol intake, salt intake before they come back, they might make all the difference. So,
good points. Thank you.
Mm-hmm.
Do we have any other questions or comments? Please feel free to type them into the chat box or use the raise your hand feature, and I can unmute your phone.
So should we go forward with the case study? And if you get questions, please feel free to interrupt me, okay?
Yep, go ahead.
All right, so basically I was just gonna, the case study is a 72-year-old African-American female, comes into the clinic for the annual exam. Blood pressure was found to be 158/90. And that was when your healthcare assistant took it. Patient has well-controlled diabetes, but no other health problems. And in the past, her blood pressure has been lower, 140/80-ish. Her BMI is 35. So what is your next step? Obviously, probably recheck the blood pressure. Then it still remained high. And then what we need to do is discuss options for treatment, lifestyle versus medications. Does anyone have any thoughts on that? Victoria can unmute if you want to raise your hand for anybody.
Yep.
Nobody wants to take a stab at it?
Mm-hmm.
Well, I think that, as with everybody, you're going to talk about the lifestyles, and even what we just talked about briefly here, it's really important for these kinds of patients to have a chance to kind of make some changes before you jump in with medicines. I think that a long discussion. Her BMI is 35, looking at that, looking at her salt intake. But you really need to make sure that you have her back, because she's certainly at high risk between the diabetes. If you were to do the ASCVD, I didn't have a cholesterol level here, but she would certainly be at high risk for coronary artery disease. And as some of the studies have shown, you know, the older population, it is important, if they're healthy otherwise, to really do this, because they have that higher risk factor to really get the blood pressure under control. So she's back after a month of trying the lifestyle blood pressures and doing her blood pressures at home. And they actually still were high, 148/88, 156/90. And today's blood pressure average was 152/90. You will find that some of the studies think that there's about a 10, could be as much as a 10 millimeter difference between home and here. So if people are 120 at home, they may be closer to 130. Again, you know, it's that accuracy of the blood pressure that comes into play in a lot of these. So what kind of pharmacological treatment would be best for her? We're probably going to go with the thiazide or the thiazide class for her in terms of that. You do have to tell her that that may have a little more urination. Some people it's significant and they really don't want to take these medicines. The other thing is you want to make sure that you have the potassium level before to make sure that she's at a high enough level of potassium that that's not a concern, and to talk with her potentially about, you know, taking in some additional potassium. And then when should you have follow-up is typically according to the recommendations monthly, and until you get that blood pressure under control. So I'm going to close here with just that, you know, there'll be changes. What I've told you today is what is available today in terms of the evidence. Every day we get changes, and we also have to help our patients to understand that, because what we might have told them, you know, last year may change this year. So the only thing we can guarantee that there to anybody in life is that there's always changes ahead.
Okay. So if we don't have any, do we have any other questions or comments for our presenter first? Okay. Well, if we don't have any questions or comments, we can go ahead and sign off. If you come up with a question or a comment later, please feel free to email me directly, and then I can pass it along to our presenter. And then, or you can indicate it on your evaluation, and then I can pass those along to our presenter as well, that through the evaluations as well. We'll go ahead and sign off. Thank you everybody for joining us, and have a great day.